you very much for inviting me to speak about Vivas. With me this evening, I have Laura Reynolds, who you'll recognise as our clinical lecturer here in Manchester in paediatrics. And when you asked me to do a lecture on Vivas, I thought, well, I've done lots of lectures where I sit here and say, do this, do that, whatever. And it's much easier if you actually get to see a Viva. So what we've done, Laura and I, we've recorded 2 different Vivas, one with a student who fails spectacularly, but he's only acting. And then the other is the same student doing the same Viva, and then he's getting an A-star level. So we'll go through both and give you an idea of what to do and what not to do. If it would be nice, it would be quite interactive. So if you want to put a hand up at some point, I'm not sure if I'm going to see all the hands, Owen. Will you keep an eye for me?
Yeah, we'll keep an eye for you.
If somebody wants to say something halfway through, that's absolutely fine. So with Vivas, you're going to come across them again and again. Certainly for any of you who feel like specialising, you will get Vivas on your specialist exams and in your consultant exams. And they will be pretty similar structures, maybe vary a little bit in timing. Here in Manchester, your clinical case Vivas will be 20 minutes. So that's what we've recorded our mock Vivas to, just to give you a good idea of the length of time involved. Remember, it is a discussion. And while you might have a good amount of knowledge, which is great, there is a structure to a Viva, and I suppose you do need to practice giving the information and giving it in a succinct enough form that you move on and get marks in the next section. So knowing it's 20 minutes, knowing that you've got a certain amount of information to get through, you need to structure what you say and not take too long meandering or giving additional information that you don't need. And we'll see that as we go through these mock Vivas. Read the background carefully. So this mock that we recorded is actually the mock that you guys did in Manchester quite recently in Peds Ortho. So you'd be familiar with it, but we will have a look at the background, and it gives a lot of the information for the questions you're going to get. So there are some red flags that we'll see as we go through. And if you see those, you know I'm going to get asked, for example, somebody's come with their stepfather, you're going to get asked about parental responsibility. So you can tell that from the background. And when you have that in advance, you're able to prepare those answers. Do always consider medical history, do consider dental background, and do consider social history before you go on to the actual clinical case. So I just put one slide, what not to do. Most of our Vivas nowadays are online, but you still don't want to dress too casually. Just, don't come dressed shabbily or, in your pajamas or, tracksuit or something like that. So you want to make some sort of effort to look presentable. You don't want to spend too long when you're asked to describe the photos and radiographs. And that's something that I see a lot in Vivas. People give every little minutiae of the radiograph, and then you don't get enough time to move on to the other marks that you need to get. And when I say don't waste time, I mean, you don't want to, give an aside such as, so I would do Socrates and then go through the whole thing. You could ask the examiner, would you like me to describe that? If they say no, it means that you got the marks you have and you just move on to something else. So it is quite a good tip to ask, should I expand on that, or do you want me to move on? Don't omit crucial diagnoses. So if there's something very obvious and that's what's causing the patient pain, you don't want to forget about that. You don't want to focus in on just one thing and leave out all the others. And don't ignore social history in pediatrics at every level. So from undergrad level to applying for specialist training to specialist exam, if you don't notice safeguarding, you will fail. And it's what we call a red flag. There are lots of other things you can get wrong and you can possibly get through, but if you miss safeguarding, we cannot let you through. So check the background carefully. And if you're asked, do you have any other concerns? It's because there are other concerns. So you can be led a little by the examiner if you haven't noticed it initially. So I'll just show you the background to this case actually before we move on. So this is the case we did as our mock, and this is the amount of information that we got. So Luke is 14. He's got autism spectrum disorder, which means you will be asked about that. You will be asked a definition. You will be asked caries risk. You will be asked how that might affect your dental management. He lives with mother, stepfather, and 7 siblings. So again, social history, he's got 7 siblings. You're wondering how the family are managing. And in fact, when you come onto the scenario, you see he's come with his stepdad. Absolutely, you need to find out who has parental responsibility. And if you don't, you will possibly be asked. He's got a history of pain associated with lower anterior teeth. He's come in pain. Your immediate management is going to have to be to deal with the pain associated with his lower anterior teeth. So no matter what else is in your management plan, and you will have a medium term and a long term, you need to deal with that pain as soon as possible. He tells you he fell at school 2 years ago, delayed presentation. Immediately you're thinking safeguarding. Is there a risk of neglect? So he banged his lower right one, lower left one. Again, that's a tip. You're going to look at the photos and radiographs and wonder, are they non-vital? Is the obvious thing. It's his first dental appointment. He's 14. Again, why? And you know there have been 5 previous appointments that he was not brought to. So again, you're thinking, is this dental neglect or is there another reason? And to make it even more obvious, we've said his clothes are dirty and his head lice. So these are all red flags that you can't ignore when you make your management plan. Okay, so we will go to our first Viva. Now, as I go through, I will stop and say, actually, this is what I'm thinking from my side. And I know for you guys, you're familiar with your own Viva, but you don't get to see a Viva quite often. And it's much more obvious when you see it's happening, what you should do and what you shouldn't do. This is brought to us by Oliver Ryder, who is acting really, really well in this. And
I'm not acting.
Hopefully you're acting in this one, Oliver, because you have managed to fail it really, really well. And the brief was that you fail. So that's what we wanted him to do. So we did go through beforehand in your defense, Oliver, and say, we would like you to, do a number of things. So let's just have a look and see how he got on. I hope it will play for you now. Good afternoon. Welcome to your Paediatric Ortho Viva. Hi, I'm Siobhan Barry, consultant pediatric dentistry here in Manchester. You know me, and this is Dr. Reynolds, one of our lecturers. And it's going to be 20-minute Viva, and we're going to alternate with questions for you.
Yeah, okay. Yeah.
I'll share my screen. Can I confirm your student number, please?
Yeah, it's 1, 2, 3, 4, 5, 6, 7.
Thank you. And can you see my screen?
Yes, I can see your screen. Yeah.
Okay, and you've had a look at this case already?
Yeah, I had a quick look. Yeah.
So I probably wouldn't start with I had a quick look. It's not a great start to the Viva, but okay. Hopefully you've had an in-depth look at the question. Lovely. Can we start by looking at this clinical photo, and do you want to describe what you see here, please?
Yeah, I see a picture of teeth. I see an upper right 7, an upper right 6, an upper right 5, an upper right 4, an upper right 3, an upper right 2, an upper right 1, an upper left 1, an upper left B, actually that might be a 2, upper left 2, upper left 3, upper left 4, an upper left 5, upper left 6, an upper left 7, a lower left 6. Don't you know what that is? I think that's an E, lower left E, a lower left 4, a lower left 3. I can't see the front teeth, so I'm just going to move on from then. Lower right 4. Don't really know what that is. I think that's the lower right 6. Yeah, and that's it, I think.
Okay, and what do you think of the gingival condition?
Yeah, I think he's doing quite a good job. Yeah, no problems there. Yeah.
And have you any comment to make on the patient's occlusion?
Yeah, he's biting. He's got an increased overbite. Yeah, he's got an increased overbite.
And do you have anything else to add to your description of that photo?
No, not really.
Okay, we'll move on to the. So looking at that was a very, very slow and painful description of the teeth. And it's much, much easier to say, I can see all primary teeth present apart from lower 5s. and I can see lower left E, in for occluding. Gingival condition, so again, this would count as a lot of prompting to get a description. He didn't mention the gingival condition initially. He didn't mention his little bit of inflammation there now. So oral hygiene, you could say there's some room for improvement. He didn't mention the occlusion. And again, I had to ask him, and he said, well, they're biting together. It's much better to make sure you use your dental terminology. So you could say, I can see an increase over bite. It looks like class 2 division 2 incisor relationship. And volunteer that information beforehand as succinctly as you can.
And I think if you just approach every scenario exactly the same way, so whenever you're describing a clinical photo, just have a bullet point list of things that you need to talk about, and it can just prompt you. So, bullet point 1, say what you see. What's the photograph of? Bullet point number 2, what's the dentition? Is it the mixed dentition, permanent dentition? Next point, soft tissues. Describe the soft tissues, and then you can go on to the teeth. And if you just approach it in that systematic way each time, your answers will just appear much more structured and logical, and you'll be less likely to miss things, because I think things like the occlusion are often overlooked. Do you agree, Professor Berry?
Yeah,
in
absolutely.
If you take the same approach with every single viva, and it's the same for the radiographs, I don't think you can go wrong.
No, have a list of things you need to mention and just list them off. And then that's it, you've got your marks. You can move on. So let's see Oliver describing the
radiograph. If you'd like to describe this radiograph, what you see.
Yeah, so I see a radiograph of his teeth. It's DPT. Yeah, I see a follicule, quite small, the upper right 8, upper right 7, the upper right 6, the upper right 5, the upper right 4, the upper right 3, the upper right 2, upper left 1. Oh no, I was doing the wrong side. Sorry. No, upper right 1, upper left 1, upper left 2.
What's missing here, rather than just counting all the teeth? Can you notice anything missing?
You see, at that point, I'm getting frustrated that I'm sitting through the same thing again as I got in the photos. And all I want to know is all permanent teeth present apart from lower flaps. Something like that would be absolutely fine, including the development buds of the 8s. You could say, upper left 8 isn't immediately obvious, but we're not too interested in those. But certainly you don't need to go through every tooth individually.
Yeah, I can. There's no upper left 8, and there's no lower left 5.
Okay, and do you notice anything else about the radiograph?
It's quite a good one. I'd say this is diagnostically acceptable.
Okay.
Oh, sorry, I don't want to miss it. There's a cyst-looking lesion around the lower incisors as well.
Okay, how would you describe that?
It's dark. It's the whole length of the incisors, and the 2 left teeth have moved a bit.
Okay, and do you notice anything else unusual on the DPT?
Yeah, the left sinus is a bit lower than the right.
And anything else? So when we looked at what teeth were present or absent, have you noticed anything unusual there?
Have I said the left 5 was missing already? I don't know if I did. The lower left 5 is missing.
Anything else?
The lower right 5 is missing as well.
Okay, and what do you think of this teeth here?
Oh, is that an E? Yeah. Oh, yes. It's the lower left E, and it shouldn't be there because the one on the right's not there.
And what do you think of its position relative to the other teeth?
Looks about right to me. Yeah. No comment.
So again, if you're asked something about what do you think of the position, we are prompting you, and it means that there is something unusual about the position. No, in that it's in for occluding.
Okay, and what do you think of this upper right tooth? You know, is there anything unusual about that?
Well, looking at the left one, it looks a little bit different to the left one, but nothing. I don't think there's any. I think it could just be an anomaly on the radiograph. I don't think there's anything wrong with it now.
Okay, I'll hand over to Dr. Reynolds for question 2.
Okay, Oliver, so could you describe your management plan, please, for this patient?
Yeah, so looking at that, first of all, I would want to know why he's missing teeth. So I think he could go for perhaps some genetic testing to figure out why he's missing those teeth.
Now, bear in mind, this patient came to see you because he's got pain. So the first thing you do is not refer him for genetic testing. You need to diagnose the reason and you need to manage that pain.
Then I would probably crack on with root canals on those front 4 teeth, because I can't tell what tooth is infected, so I assume it's all 4. So I'd probably at that appointment obturate, clean and shape, do the whole thing in that appointment, and then with that little E on the left there, I'd probably just take that out on the day. Yeah, it's good for kids to get it all done quickly. I think sort of shock therapy. Yeah.
What would your preventative regime be for this patient?
What do you mean by that?
So your caries prevention and management plan, what sort of preventative regime would you instigate?
Well, it's very important to have a preventative management. So I'm just going to have a drink.
So again, that's classic time wasting. If you don't know the answer, it's quite tempting to say either repeat the question or put in some fillers like that, but it's not giving us any information, it's not giving you any marks. So if you're asked prevention, give a list immediately.
Is it recorded? Watch it later.
High fluoride toothpaste, 5,000 ppm would be appropriate for this patient.
No, I couldn't hold it in. Okay, I had to laugh there.
Fish.
So that's the wrong thing to say, but okay, we'll move on.
Fissure sealing, those 6s possibly as well, because we should fissure seal all teeth that have molars. We should fissure seal all of them, and I'd want to know whether he's having a lot of sugar as well. So I would ask him whether he has a lot of sugar, and then tell him to stop eating so much.
Okay, and then just going back to the lower left E, which you did touch on briefly before, what do you think would be the most appropriate management plan for that tooth?
I think I said take it out, and I stand by that.
Okay, and do you think there'd be any benefits to retaining that tooth?
Well, it's a baby tooth, and I think this patient is 14, so he's not a baby. So no, I think it should come out.
Okay, right, I'll hand over to.
So being led like that, obviously there is a reason to maintain that tooth, which is maintaining bone space, aesthetics, function. And if we ask you again, but do you think there's any reason you might keep it? There usually is. So just, have a little think about that and try to consider the other options.
That's fair enough. The next question.
Okay, so looking at his history, you can see this boy has autism spectrum disorder.
Yeah.
What do you understand by that?
It's a disability. I know that, and it means that they think differently to us, and he wouldn't really like the dentist as much as other kids. So I might have some problems with him sitting in the chair, and he might not open his mouth.
I see quite a bit of this in Vivas, where I ask you what is something, and people haven't learned the definition. And while you might know, in abstract terms, what autism spectrum disorder is, it's quite difficult to explain it when you're under pressure if you haven't learned the definition. So I'm a big fan of just learning off the definition for these things. And then you can just recite that quite quickly and just get your marks.
And do you know how autism spectrum disorder can manifest? So what might you notice in a patient? So yes, maybe not liking to sit in a chair, or maybe not liking to open, but any other way that it might affect the patient?
Could you repeat that? Sorry.
So, for example, do you think there might be any issue with communication?
No, not really, because I've met quite a few kids that have been autistic, and they've all been quite vocal, really. I've had it might be a bit apprehensive to start, but not a lot different to any other child, no.
Okay, and you've mentioned some of the challenges this patient might face. What other challenges could you see in providing care for this patient?
Oh, sorry, I'm getting a bit flustered. Would you mind repeating that?
Okay. And so what challenges might patients with autism spectrum disorder face when accessing dental care?
Well, they don't like it, for one. And perhaps their mum and dad don't like bringing them in so much. So parents might avoid it more because they know they'll play up at the appointment.
Okay, and you've said you do some root treatments on this patient.
Yeah.
How might you do that if the patient's anxious, for example? Because you said he might not want to sit in a chair. What options would you have for somebody 14?
GA is the way in this case.
So notice he's completely missed local analgesia, inhalation sedation, IV sedation. And while you might think GA is the most appropriate option, you do need to give every option. And then you can always say, but I think in this case, it's more than, it's likely he would need a GA. But you certainly should mention all the others.
And I think that getting him in and putting him to sleep would definitely be the best option for him. And just getting on with it.
And if this patient did need a general anaesthetic, how would that change your management, if at all? So would you, for example, still go ahead and retreat these lower anteriors?
Yeah. I mean, I don't see any reason why not to. I mean, to be honest, if he was asleep, it'd probably be a bit easier.
Okay, and do you think you'd manage to do all that treatment in one? Or do you think you might need a second general anaesthetic?
I think because it's a general anaesthetic, I'd do it all in one. So I'd obturate on the day as well. Yeah, and I'm and I'd do it all the day, and I'd get that E out as well.
Okay, so you'd extract the E in the same visit.
Yeah. Oh yeah.
Would you see any problem with this large area? So if you wanted to obturate on the day,
I'd make sure the GP didn't go into it.
Yeah.
Yeah, I think because if you overfilled and you poked it with the GP, I presume you could make it worse. I'd make sure I didn't do that. Yeah.
Okay, I'll hand back to Dr. Reynolds for the next question.
Okay.
Okay, Oliver. So, do you have any other concerns about Luke's background?
I was a little bit suspicious about the dirty clothes, but then I thought, he could have been out playing footy, and a lot of kids could have dirty clothes. And head lice is pretty normal. So I had head lice. I think a lot of kids did. So not really. I mean, I did initially think, why is he here 2 years later after having the full? That was a bit odd. So I'd probably ask about that. I think that'd be an idea. But from reading the history, at least he's been brought to the dentist. I mean, that's a good thing. And if the parents really didn't care, they wouldn't even bring him. So I might ask about it, yeah. But I would be overly concerned, no.
And what do you think about the head lice?
Yeah, well, as I say, I had it. My sister had it. A lot of people in school had it. So, I mean, I'd probably just, it's a bit of an awkward conversation to breach, really, isn't it, with the parent? I mean, I would want someone telling me my kid had head lice. I'd probably, move on.
And we know that Luke was brought to the appointment by his stepfather. Is there anyone else you might want to talk to about his diagnosis and about his care?
I think it's really nice his stepfather's brought him, to be honest, because I know a lot of kids don't have a very good relationship with step parents. So I definitely discussed treatment with him, and and I'd say to him, let the mum know what's happened this appointment as well, because it's important for the mum to know. Yeah, it's important for the mum to know, because if I was the stepdad, I would tell the mum, and I'd want to know as well. So you should tell the mum.
And if you did have concerns about this child's well-being and you wanted to make a referral to social services, how would you go about that? Would you inform the stepfather or the patient's mother about that referral?
I mean, it's a bit awkward, isn't it? So I think for most safeguarding referrals, keep your cards close to your chest, and you just do it, really. I don't want to fight with someone. I'm not very confrontational, so I'd probably just, I'd even get someone else to do it. I mean, if I had to have a conversation, I think as a newly qualified dentist, I think someone else should have that conversation, or just not do it. Yeah.
Is there anyone else you might want to gather a little bit more information from, apart from the child's mother? Anyone else that might be involved with Luke's care that might have a little bit of information that could be of help before you were to make any referral to social services?
Could speak to his teacher, possibly. That might be an idea. Yeah, I'd speak to his teacher.
Okay, fine. I'll hand back over to Professor Barry for the next question.
Okay, so
that's a clear fail on the safeguarding section. So at this point, you've already failed the Viva, Oliver. Not being concerned about the patient, not being willing to raise concerns. And he acknowledged that if he was concerned, he wouldn't want to raise it. And again, that is totally unsafe. So you would not be able to pass a Viva giving that answer.
Last question now, Oliver.
That's going fast.
Do you think this patient benefits from orthodontic intervention?
Could you go back up to the pictures, please?
Yeah, there you are.
I mean, looking at that, if they were my teeth, I'd be quite happy with the way they looked. And orthodontics is an aesthetic practice, really, isn't it? So
what do you think of these other twos, size-wise?
Yeah, I mean, I'd offer him composite bonding if he wanted it, because smile design is quite a passion of mine. That's not orthodontics, is it? So, but I might, out of courtesy, let them know about the E and the general anaesthetic, because they probably know a bit more than me about that. But the likelihood is, I'm pretty certain you need to take that out. So I might not even ask, really. I don't know. Yeah, but I don't think orthodontics will be massively helpful for this chap, no.
So going forward, and you said that this patient's hypodontia, so he's missing his lower fives, they're developmentally absent. Do you think there's any need to involve an orthodontist in treatment planning for that space?
Yeah, so when it comes to congenitally absent, I think is the term.
So don't contradict the examiner in the middle of your Viva if you can. That will be a good way forward. And of course, fives are developmentally absent because you're not born with them. So they can't be congenitally absent. Nobody has fives when they're born.
Fives. I'm pretty sure that when he turns 18, I could just do Invisalign on that. So, no. And to be honest, a lot of orthodontics is done by GDPs now, and I could probably do that with Invisalign, I would have thought, to close that space, or just leave.
And one of the big issues here is not not knowing how this case might be managed orthodontically so much as not being willing to ask, not being willing to appropriately ask for help. So we would want you to say that you would ask for an orthodontic opinion in this case for sure. Because
it's not going to do him any harm, is it?
Well, that's your 20 minutes, Albert. Thank you very much for that.
Yeah. Sorry, I got a bit nervous there. But no.
Okay, so that is the fail Viva. Does anybody have any comments on that before we look at the A-star Viva?
I think I'll just add, Professor Barry, I think that was a perfect example of answers that just lacked structure. It was a bit dreary, the answers dragged on, he didn't get to the point quite quickly enough. And what would be interesting for you to compare with the next scenario is that Oliver very clearly signposts each answer. So not only will he sort of make a brief statement before he starts about the next bit that he's going to talk about. So he might say, okay, and I'll now talk you through the patient's caries prevention regime, for example. He also checks in with the examiner at regular intervals and says, would you like me to expand on that before I carry on to the next bit? So it'll be interesting for you to just compare and contrast the two responses, because I think it's quite noticeable.
Yeah, and what I found in this next Viva is when I opened my mouth to ask the next question, he already started answering it, which is great. If you can do that and it's appropriate, absolutely, you can keep going. And as Laura said, very succinct answers, evidence as and when he had it, which is absolutely great, and just very much to the point, which is what you want. So I just said really, dress smartly, clear, concise descriptions and structure. It's all about structure, and that's something that you can have in place beforehand, because usually you've got a bit of time before these Vivas, so you can write out your answers quite nicely.
Good afternoon. This is your Peds Ortho Viva. It's going to be 20 minutes.
Oh, hi.
I'm Siobhan Barry. Hello. You know me, I'm one of the consultants of paediatric dentistry, and this is Dr. Reynolds, who is our clinical lecturer. And we will take in turns to ask you some questions.
Okay, fantastic.
Can you just confirm your student number for me, please?
Yeah, sure. It's 1, 2, 3, 4, 5, 6, 7.
Lovely. And you've had a look at the case?
I have, yes.
And are you able to see my screen?
I am, yes.
That's great. So let's get started with the first question, which is having a look at the photos. And would you like to describe this clinical photo here for me?
Yeah, of course. So I see an intraoral frontal view of the patient's dentition. On the maxilla, we can see the upper right 7 to upper left 7 are present, with no pathologies of note to detect. However, on the upper right one, we can see a small white opacity in the lower coronal third. On the mandible, we can see lower left 6 to lower right 6, however the 5s are not present. And the lower left E is retained and severely infraoccluded. The patient has an increased overbite, which is greater than 2/3. There's gingival inflammation present, which is localized to the upper left quadrant. The patient has peg-shaped laterals, and there's a centerline shift, which appears 1 millimeter to the left. Generally, his oral hygiene appears good.
Thank you. And we'll move on to the radiograph here, if you'd like to describe that one for me.
Yeah, so I see a full DPT radiograph of the patient's dentition. On the maxilla, I see the upper left 7 to the upper right 7 is erupted, and there is an upper right 8 follicule. On the lower dentition, I see the lower left 7, 6, E, 4, 3, 2, 1, lower right 1, 2, 3, 4, missing 5, 6, 7, and unerupted 8. It shows that the upper left 8 is missing, as well as the lower left 5 and lower right 5. There's dens invagitus present on the upper right 2, and the lower left E is retained infraoccluded. The lower right 6 has begun to tip mesially into the space of the missing lower right 5. That's a large periapical area associated with the lower 4 mandibular incisors, which appears to be indicative of a large periapical abscess.
Okay, thank you.
So that's pretty much as good as you're going to get it, a very clear, structured overview of both. And can you see how much quicker Oliver's answered this one than in the first Viva? And he's got a lot more marks.
I will pass you over to Dr. Reynolds for the second question then.
So Oliver, what would your management plan be for this patient?
Yeah, of course. So I'm assuming from the information provided to me at the beginning that a full medical, dental and social history has been taken. My first issue here is with consent. Because I saw that Luke is attended with a stepfather who we can assume is unable to consent with Luke's treatment unless he presents with documentation as to indicate otherwise. He may present with a parental responsibility order, for example, however it's unlikely. This really limits the treatment we can provide to Tay. We must see if Luke's mother is able to come in. First thing I want to do is I'll focus on the trauma. I want to ensure that this clinical presentation of the trauma and the history match up. And if Luke makes a direct allegation of abuse, and this is a cause of concern, I would want to find out more about the pain Luke's experiencing. So I'd want to take a Socrates for this. So would you like me to go through Socrates?
No, it's okay. You can carry on.
Okay, I'd also want to find more about Luke's ASD, but I'll come on to this later. My next stage would be to take a trauma stamp of the mandibular anterior incisors. This would be assessing if there's any dentine exposure present. I'd do density percussion testing, so a tapping with a blunt end of a mirror would do the job for this. I'd do ethyl chloride testing, a sensibility test, and a lack of response would indicate the lack of an intact nerve. I'd do Doppler flow testing if it was available, and that's the only true way to determine vitality. I'd check if there's a sinus present or mobility. At this appointment, I would be able to provide emergency treatment for Luke. Emergency treatment would involve extirpation of the lower incisor or incisors, which are demonstrating a loss of vitality. It'd be a good idea to phone Luke's mother and inform her of the treatment performed. Also, if dentine is exposed, then I'd place a dentine bandage on the exposed dentine. Would you like me to go on to prevention?
Yes, please.
So this is a key aspect to any case, and indeed in paediatrics, any case should have a restorative and a preventative component. So I'd like to find out more about how Luke looks after his dentition. Luke has autism spectrum disorder, which puts him into a higher need of care risk category than other children due to the barriers of care that he'll face. So I've followed DVOH and I've put intensive prevention in place. I'd applied fluoride varnish 2 or more times yearly, and there was a systematic review which showed a 37% reduction in DMFS in primary teeth and a 43% reduction in permanent teeth. I'd ask him to use a fluoride mouth rinse at different times of brushing. There was a Cochrane review on this as well, which showed a 27% reduction in DMFS in permanent teeth. I'd also prescribe to 2,800% fluoride toothpaste if he could tolerate it, and that's shown to have a 24% reduction in caries. I'd also reduce recall to 3 monthly according to the NICE guidelines, because as I say, he has a high barriers to care. Would you like me to move on to the stabilisation phase of this treatment?
Yes, please.
So at this appointment, I would like Luke's mother to be present for consent reasons, and a full treatment plan could then be performed. So I can see the upper right tooth has a dentin vagitus, which is present. So I'd take a periapical radiograph of this tooth and perform sensibility testing. Hopefully it'll be vital and associated with no periapical pathology. In this case, it could be fissure sealed. If not, it will need to be extirpated and undergo orthograde RCT. I've noticed I don't have any bite wings in this case, so I'd like to take bite wings as well as part of any preventative measure.
So if you don't have bite wings, I would always suggest you need them for caries diagnosis, because while you might note lesions on a DPT, it's not appropriate for caries diagnosis. So it's always good to say I would need some bite wings to decide on which lesions I need to restore.
Take bite wings. I see that the lower left E is retained infraoccluded. However, the lower left 5 is missing. So the lower left E is acting as a fantastic space maintainer. I'd need an orthodontic opinion. But there are two options here. I could retain the lower left E and potentially provide a composite onlay to prolong its life. And Luke and his parents should be informed this tooth is a finite life and would eventually be lost. I could also extract the lower left E and gain orthodontic input about how to manage this space and refer them to an interdisciplinary clinic for this. The space could be closed orthodontically, or a prosthesis could be replaced to replace this. I take a full plaque and bleeding score for Luke because I've noticed he does have a little bit of a gingival inflammation in his upper left quadrant, so there's no harm in doing that, providing some oral hygiene instruction. Would you like me to move on to the restorative phase?
Yes, please.
So in this stage, if any of the lower four mandibular incisors were excavated, which I'm sure they were, then another PA should be taken at this stage to see if there's been some resolution of the radiolucency 3 to 4 weeks later. If there has been, then obturation can be performed. If not, then redress. But it is of critical importance that there are no symptoms in this tooth and no pus being extruded from the canal before obturation. I wouldn't place MTA plugs in this case because the apices are closed. The incisor edges of these four incisors can be restored using simple composite restorations. And coming back to this, if this root canal doesn't work, and for example, if this lesion persists, there's a high chance this is actually turning into a cystic lesion. In this case, I would refer to restorative, and they could potentially do orthograde RCT and enucleation, but that would depend on whether this is resolving.
So that's really excellent. It shows not only are you considering the immediate and the medium-term management of these incisors, and by retreating them, but you're looking to the future and you're considering what will you do if it doesn't resolve, who might you refer to, and what might the outcome be. And giving that without prompting would get you a lot higher marks.
I'd probably leave the peg-shaped laterals, as aesthetically they appear okay, but it's important to gauge the child and parents whether they think this is a bigger issue than a big issue. If the patient is not happy, you could consider just doing freehand composites on these. There's no harm in that. Would you like me to move into the maintenance phase?
Yes, please.
So in this case, I'd review the patient clinically and radiographically at 6 to 8 weeks and 1 year. I'll be checking for colour changes, loss of vitality, and root resorption. And I'd keep on top of his oral hygiene. I'd keep providing intensive prevention. And like I said, I'd reduce his recall interval to 3 months in this case because of he has a high need for treatment due to his barriers of care due to the fact he's autistic.
Okay, thank you, Oliver. I think I'll pass it to Professor Barry for the next question.
Thank you. So you mentioned that Luke has autism spectrum disorder. What do you understand by that?
Yeah, so autism spectrum disorders, they're a group of lifelong neurodevelopmental disorders characterized by severe impairment of social reciprocity, behavior, and communication. Their prevalence in society is 1 in 88.
So isn't that so much easier than in the previous Viva? Very succinct, and literally that's all we need to know to move on to the next part.
Okay, and what sorts of barriers to care might these children note when they're accessing dental care?
Yeah, so poor oral hygiene, which is due to poor manual dexterity. And there was a study by Kalionku et al. In 2017, which showed considerably lower oral hygiene levels in children with ASD, but similar caries experience. When you think about why this is, it's most likely because parents will struggle to brush these children's teeth. So they'll struggle to get all the surfaces, so they'll have an increased plaque accumulation. However, preventing caries is more to do with the fluoride that's in the toothpaste. So they'll often be able to get the fluoride into the child's mouth, but would be unable to remove the plaque. They also have an increased risk of dental erosion due to an increased prevalence of gastroesophageal reflux disease. And there was a study by Coves et al. In 2002, which showed that 69% of children with ASD suffered from gastroesophageal reflux disease. Also, they're at an increased risk of trauma. And yet another study by someone called Alton et al. In 2010 showed that children with ASD are 8% more likely to undergo a traumatic dental injury than the control group without ASD. It also has a profound effect in the way we treat these patients, because children with autism spectrum disorder often have a difficulty expressing pain. It doesn't appear to be a problem with Luke in this case, because he's clearly said he's in pain. But also children with ASD might not like busy waiting rooms, and they can feel overwhelmed. So it's useful to often treat these children early in the day or first thing in the afternoon session. They also might not like bright lights, loud noises, or having their head touched. Would you like some tips on how to treat these children?
Okay.
Yeah, so routine, this is incredibly important for children with autism spectrum disorder. It's important for Luke to see the same dentist and dental nurse every appointment. It can be useful to call Luke's mother or stepfather up in advance to find out what Luke likes and doesn't like, and some tips on how to treat him. Positive reinforcement is incredibly successful in these patients often. And whilst Luke might not like having his head touched or being touched in a manner, some children with ASD are actually reassured by deep touch. So placing something like a lead apron on them can reassure them and make them feel more safe. Distraction, for example, diverting loose attention to another stimuli, for example, putting a film on during treatment can help. And many children with autism spectrum disorder don't like the taste of dental elements, so the use of flavor-free toothpaste such as Oranus may improve his compliance.
And you did mention anxiety for Luke. When you're doing your root treatments in the lower incisors, what are your options for that?
Yeah, of course. So there are a few options. One of them is doing them under local anaesthetic. This is ideal, but it really does depend on how Luke could tolerate treatment. Another one which could be used potentially is nitrous oxide. But with autistic patients, they have to really buy into nitrous oxide because it relies on psychological reassurance. So often nitrous oxide isn't too successful in autistic patients. You could also do sedation, but yet again, in autistic patients, it's difficult to cannulate them and they probably won't tolerate it. The final option, which is another good option for children with autism, is to do this under general anaesthesia. Of course, there's a risk of general anaesthesia such as 3 to 4 in 1 million chance of death. And also it's a bit of a rigmarole for the parents. It's a whole day out. So ideally under local anaesthetic, but it may have to be under general anaesthetic. But if it was under general anaesthetic, I'd probably have to consider changing my treatment plan because...
So again, that's excellent. And you always need to consider how you might do the treatment and how things may change, if at all. But generally, we find that under general anaesthetic, we're a little more radical. And it may be that we're considering extracting teeth that we may restore under local or sedation. Or it may be that we consider things such as extirpating under GA and then completing the treatment on the chair. So there are lots of different options, but it's just considering how things might change and saying that before you're asked.
Doing root canal therapy under general anaesthetic is quite difficult because it can often require more than one general anaesthetic. So in this case, it might be that you have to consider extractions of these incisors under general anaesthetic. And it's also really, really important to source an orthodontic opinion before general anaesthetic to avoid the need for further general anaesthetics.
Thank you. I'll hand back over to Dr. Reynolds for the next question.
So Oliver, are there any other concerns that you have regarding Luke's history?
Yeah, absolutely. So first of all, I want to split this question into two. One from the side of dental neglect and one from the side of his dirty clothes and failed appointments. So the dental neglect side of things, I can see that Luke hasn't been brought here. It's been a delayed presentation of this injury. And why wasn't Luke brought at the same time? So this is immediately a cause for concern. And I'd ask open-ended probing questions as to why Luke wasn't brought at the time. I know he was brought now, but it's really confusing as to why. If he was in pain, he wasn't brought earlier. So I'd be looking for signs of foul play, such as a direct allegation from Luke that this wasn't an accidental injury. I'd be looking for discrepancies between the history of the injury and the presentation, and of course delayed presentation, which in this case he has. So in this case, I'd take a full history exam. I try to talk to Luke separately. I try to gauge what's happened here, and then if I still have concerns, I've talked to a senior colleague. And if they had concerns, well, then in that case, I'd be considering that this could be potentially abuse if it was a non-accidental injury. And in that case, I could do a Section 47 child at risk referral. And in that case, I wouldn't need the consent of Luke's stepfather or mother in this case. But ideally, I should sort it. But when coming to his failed appointments, dirty clothes and head lice, from reading Luke's history, I can see that he has 7 siblings, and this is a very large family, and we shouldn't immediately jump to assumptions of neglect. It may be that the mother and stepfather are struggling to look after so many children. And there are numerous explanations for having dirty clothes, especially at 14. It may be that Luke had been at the park with his friends just before the appointment, and head lice are very common in school children, so this doesn't immediately point towards neglect. But I would certainly point these out to the stepfather, and gauge his reaction. If he shows genuine concern, then it may be that he just is feeling a little bit overwhelmed with treating and having so many children, or just didn't notice. I'd also ask why these appointments are missed. Yet again, I can bring this back to the fact he has 7 siblings. It can be very, very hard to keep on top of everything that's going on. So I'll talk to them in a non-judgmental manner with open questions. And like I said earlier, trying to talk to Luke alone is ideal. Get him into an X-ray room and ask him some questions about how things are at home. If I had concerns about Luke's well-being, I could talk to the safeguarding lead in the practice. And if they have concerns, then a Section 17 child in need referral may be warranted. And it could be, but before this, it might be an idea to book Luke in again in 2 weeks to see if the issues that I pointed out have been resolved. If not, then I'd send a safeguarding referral. I'd want to get a safeguarding referral consent from Luke's mother and explain that it's not necessarily because they're doing a bad job, but that because they could use some help at home. There is a great document, Child Protection and Dental Team by the BDA, which is where I got all this information from, and it's a fantastic resource.
Thank you, Oliver. I'll hand over to Professor Barry for the next question.
Okay, looking at Luke's DPT, you've noted that he's missing quite a number of teeth.
Yes.
Do you think you'd benefit from an orthodontic assessment?
Yeah, absolutely. I think he would. So Luke would benefit from an orthodontic opinion input because immediately he's a 5S on the IOTN. So he should be referred to orthodontics for an opinion prior to extracting or retaining that lower left D. Would you like a list of Luke's orthodontic problems?
Yes, please.
So he's missing lower right 5 and lower left 5. He has a retained lower left D. He has a class 2 molar relationship on the left. He has a class 2 div 2 incisor relationship, along with an increased overbite. He has a centerline shift of the mandible 1 millimeter to the left, and a posterior open bite on the left-hand side between the upper left 4 and lower left 4. Would you like a proposed treatment plan?
Yes, please.
Yeah, so removable appliance using a labial bow to procline the upper incisors and an anterior bite plate to reduce the overbite would be an idea. This would reduce the overbite and convert the class 2 div 2 into a class 2 div 1. At this point, because Luke is beyond the age of being able to use functional appliances and growth modification, his option at this point would most likely be camouflage treatment, which would involve extraction of the upper premolars to disguise this malocclusion, and this would involve fixed appliances. Luke's an ideal candidate for camouflage because he's already missing the lower 5s, which would probably be what the orthodontist would extract to give themselves the space. The lower left E could be extracted and the lower 6s could be moved mesially to close the space left by the missing lower 5s. Alternatively, that lower left E could be retained to preserve the space, and a composite onlay could be placed. So this would all depend on the opinion of the orthodontics team.
And if Luke asked you, how long does he need to wait before he starts orthodontics following his injury to his lower incisors?
Yes, so there is a new guideline for this from the British Orthodontic Society, and it says that you should wait 6 to 12 months.
And what about this lesion here? Would you monitor that before you advise orthodontic treatment?
Yeah, absolutely. I would hope for complete resolution of that before orthodontic treatment.
Okay, thank you. That is your 20 minutes. I can let you escape.
Okay, so dramatically different Viva there. I didn't get asked to ask much at all. You got to ask even less, Laura, I think.
Yeah, true. Yeah, I thought it's brilliant example of how to approach a Viva. I think although Oliver was obviously getting a lot of information in there, I thought one of the really effective things about his approach in this second scenario was that it was actually quite interactive. So his answers were engaging the examiner. I think because obviously at the moment with often you're given the scenario sort of a week in advance to prepare, it's tempting to write a very long detailed answer and then basically just to sort of read off a script or use your notes quite heavily, and it just becomes a little bit robotic. And I think one of the things that Oliver did in that scenario was sort of set, as I mentioned before, signposting each section, say, and asking the examiner what sort of level of information they want or whether it would be good for them to move on. I thought that was particularly effective.
Yeah, and even if you are reading from notes, try not to make that obvious, as Laura said. So you want to engage with the examiner, and quite often, we're asking you something that's not in your notes, possibly. Or, it's, what would you consider appropriate for this tooth? Do you think it's appropriate to keep it, or would you crown it, etc.? And, the mistake sometimes people make is they pull up loads of papers and they're looking, and eventually I say, well, that's not going to be in your notes. This is more of a, treatment planning. What do you think of this at the moment, rather than something you can Google. So sometimes putting your notes away and just listening to the question and answering it, you will know the answer. You're not going to fail if you can't quote a paper. But if you don't listen to the examiner and look at what we're asking, that's when you run into trouble. You can work out usually what the answer is from the photo or the radiograph.
I completely agree. I think it's really off-putting as an examiner when you see lots of pieces of paper flying around, and it's a completely new phenomenon, given that this is the first year we've done this, that I've done this remotely. Because obviously pre-COVID you would have just been given the scenario 20 minutes before. You might have a couple of scraps of paper that you've written some brief notes on, but you had nowhere near the sort of amount of time to prepare as you guys have. But yeah, like Professor Barry was saying, it's sort of if I see obvious papers that you're sort of shuffling through to find the answer, it makes the examiner question whether you actually know it or not.
Yeah.
And a lot of the questions, for example, questions about prevention, you should just be able to sort of reel that off without any prompts at all. So if you're sort of having a little look at your notes about your preventative regime for a high caries risk 14-year-old, it makes me question your sort of level of understanding. So really try, and I think Oliver was a great actor, and I actually said after we finished that, I said to Oliver, I said, oh, it's great, you know, this is exactly what we want. You weren't using any notes. And he was like, oh, I was using notes. And I said, oh, I didn't even realize you were. So yeah, just not relying on them too heavily is my sort of advice, I guess.
Or worse still, obviously typing into a different computer to Google the answer mid-viva.
Yeah.
I've seen it, and it doesn't inspire confidence.
No.
As you can imagine. Frantically looking up guidelines.
Mm.
You're not going to be able to find the answer quickly enough, even if you try. So you're much better just to engage in the process and pull the information from your own mind as much as you can. What did you think of it, Oliver? How did you find doing the second Viva with your note?
Yeah, it was tougher to do the second one, definitely.
Yeah.
But I had a lot of help. But no, it was a lot of fun, and I learned a lot. I hope you guys did too.
So are there any questions about Vivas in general? Hopefully seeing both will give you a really good idea of the pitfalls that you might encounter and how to structure your answers.
Yeah, thank you everyone for watching, and thank you for all the effort put into that webinar by Laura, Oliver, and Prof. Barry. That was really, really good. A lot of good tips in there.
It was good fun. It was really good fun.
Yeah, I'm sure all the 50-years will be much more confident with the Vivas now, so I hope they all do the best. Yeah, but if anybody's got any questions, just put them in the chat and we'll get around to them. Before everyone leaves as well, I'll just remind everyone that we've got our next Viva on oral med, which is on the 22nd of April, so 2 days. And don't forget to register for that, and we'll get the cases out to you. Because for this one, I think we can send the cases to you beforehand so you can have a read. And for the recording as well, we got a lot of questions about recordings. I'm not sure, Niji, you'll know more, but the Viva might be quite soon, and I'm not sure when we'll be able to get the recordings out. We won't be able to get them out straight away. So don't rely on the recordings, is what I'm trying to say.
Yeah, we'll try and get it out as soon as possible, though.
Yeah, of course.
We've got a question, Sam.
Oh. So, do atopic conditions, e.g. asthma and hay fever, increase a child's caries risk?
Yes, asthma will increase caries risk, certainly. And a lot of asthmatics are atopic. So asthma will increase caries risk. And we know this from systematic reviews with meta-analyses that tell us that we'll double the risk in the primary and permanent dentition. It's because of the risk of enamel defects that these kids have from being hypoxemic when they're younger. It's the risk of sugary medicine. It's taking a salbutamol inhaler, which is a beta-2 agonist and will cause xerostomia. It's increased risk of nasal polyposis, which causes mouth breathing, which will exacerbate a pre-existing xerostomia. So all in all, certainly there is an increased caries risk for asthmatics and their increased priority for prevention.
Anthony has asked, what is the best way to respond to a question if you don't know the answer? It's a good question.
Say, I don't know, but I would go and look it up. It depends on what the question is. So if it's, I don't know, what is a beta-2 agonist? What's salbutamol? You could say, I don't know what that is, but I would look that up in the BNF. And I would look at any, possible side effects it might have. So at least saying you know where to look. If we say, what is fluoride toothpaste? And you say, I don't know, but I would look it up. Well, that's not going to work. It depends on what the question is. But if it's something that we don't necessarily expect you to know, if you know where to look or who to ask, then that's safe. And even when you come to consultant Vivas, some of the stuff, because they're quite complicated cases, we don't expect the candidate to know the answer. But we expect them to say, I'm not familiar with that syndrome, but I would talk to the pediatrician, I would look it up, I would consider whether there's a cardiac involvement, so it's just about being safe. It's not about knowing everything. We don't expect that at all. But not saying, this patient has hemophilia, I don't know what it is, but I'm going to go ahead and do the extraction anyway. That's when you fail.
Yeah. I got the private message that said, if we say I don't know to a question, you ask, is that an instant fail? So I think you
No, No, it's not at all. It depends what the question is, doesn't it? If it's a distinction level question, that's fine. If it's a very basic question, are you worried about safeguarding? I don't know. Well, no. Yeah, probably.
Yeah.
Okay.
That makes sense. So you're just doing your best to find a solution, even if you don't know.
You just know who to ask or know where to look.
I think there was a question at the end that was one of the trickier questions about, I think it was the orthodontic timings following trauma. That was a question I asked a couple of my own candidates in the mock. As Professor Barry said, I mean, even if you don't know the answer to that, a sensible response would be, I'm not sure, however, I'd probably have a look on the British Orthodontic Society web. You know, you'd know the sort of society that might be releasing guidelines like that. Yeah. So even if you don't know it's definitely the British Orthodontic Society, it's possible that on the website there might be some information about sort of
And I suppose you'd still get marks for that, coming up with like a sensible answer like that.
Yeah, you would, absolutely. You'd still pass with that. Yeah.
Should we go to the next one?
Yeah. So Ibrahim has asked, if you're not as preemptive with your answers, would you lose marks, or would you eventually ask the question regardless?
So when it comes to marking, you do much better if you give all the information up front, because we're very confident you know the answer. If we have to ask you loads of questions and then we drag the information out of you, it's seen as prompting, and you know you're not as confident or strong a candidate, certainly, because we lead you. You know, in many ways, you've been led to the answer rather than you coming up with it yourself.
Yeah, that makes sense.
Yeah.
And the next question is for an infra-occluded tooth. Would there be anything else to consider in terms of management?
So the way you assess an infra-occluded tooth for prognosis is look at amount of root remaining and look at the crown. Is there caries? Is there post-eruptive breakdown? And how severely infra-occluded is it? That's pretty much what you look at. You would always ask for an ortho opinion, particularly if there isn't a permanent successor. And if your options are to extract, leave as it is and monitor, or build it up to the occlusal plane, which you can do with direct composite, an indirect composite onlay, or a preform metal crown. So we don't expect you to say, this is exactly what I would do, but we would expect you to say, well, these are the options, and I would discuss this with an orthodontist. I love the words interdisciplinary management for your long-term management, because that shows you know where to send the patient, and you know that there needs to be involvement from other specialties, not just, I would extract that because I think that's the best thing to do, and I'm not going to ask anyone.
Yeah, that's a buzzword for everyone. I'm sure you'll hear that a lot this year.
Good. I'll be very pleased.
Yeah. And the last question I think we got, unless another one comes through, Alex has asked, if you panic or get confused, can you ask to come back to a question later?
Yes, it's absolutely fine. So if there are marks going for question 1 and you haven't got them, you move on to question 5, and if you say, oh, by the way, I forgot to say I would do this, yeah, that's absolutely fine. Yeah. So sometimes people say in exams, oh, the word escapes me, I'll come back to it. And then later say, oh, I forgot to say, I remember that word, and that's fine. Because we know it's very stressful. We know people, in the heat of the moment forget words. So yeah, absolutely. Just say, I've forgotten it, but don't spend ages trying to think of it. Just say, I'll come back and continue on. And usually you will remember, like hypodontia, or I don't know, whatever word you might forget.
I think that's it for our questions, if everyone's happy. Niji, do you have anything to add?
No, I don't. Just we've got our oral med one on Thursday, so make sure you tune in for that. That's at 7:30.
Sorry, could I just ask one question?
Of course.
Yeah, of course.
Basically, with the evidence that we're expected to reference, would this mainly be guidelines that we've been taught to refer to, like SDSEP, NICE, those sorts of things, or would we be expected to know individual papers, and how would that change our marks if we did quote individual papers?
You wouldn't be expected to know individual papers. Certainly we'd expect you to know the Royal College guidelines, the prevention guidelines, the common ones. And from a PEDS point of view, they're all in the handbook or the trauma handbook. Even those BOS guidelines are in the back of the trauma handbook. I was very disappointed today to know people didn't know about the erosion guidelines from the Royal College of Surgeons, as S. Barry is one of the authors. Might all want to go and look those up. But yeah, just the common guidelines. And if you know papers, the answer is that would get you much higher marks, certainly. I don't expect individual papers until specialist level. And even at specialist level, you often don't get them. If you do know one, say it. It will give you more marks. If we start to ask you for an individual paper, you've already got a distinction probably. Because I wouldn't ask you that unless I've run out of everything else to ask you, and I'm just wondering what you know at that point. So really, you know, if you know the common guidelines, so if you tell me I don't know about DBOH, well, you know, that's worrying. But if you don't know the individual papers or the Cochrane reviews, that's fine. If you do know them and Oliver put them in there and put some papers in, that will get you much higher marks is the answer. You certainly won't fail.
Are there specific papers that you expect us to refer to, or is it just...
No, I mean, I've put quite a few of them in the lectures, but I mean, if you can remember some, absolutely fine. But really, it's the common guidelines, unerupted ones, ectopic canines, sixes, you know, the erosion guidelines, DBOH, SDSEP, FGDP, NICE, just the common ones you're doing all the time. We don't expect individual papers at undergrad level. That would be too much to expect.
Yeah. Just one last question.
Particularly the ones that are written by Professor Barry.
That would be very impressive. You might remember those, yes.
One last question by Alex. If you know the paper but not the author, is it still okay to mention it, or would you be kind of digging yourself a hole?
No, it's absolutely fine. If you say, I know there's a paper that says asthmatics are at higher risk of decay, that's fine. We would accept that. We wouldn't ask you any more about it. At least you know there's a paper that says that, which is great.
I think we're really lucky in Manchester to have a PEDS guidebook to everything and a trauma one as well. So we're so lucky. Thank you so much for making that for us.
You're hoping to get me in the exam now, aren't you?
Hope so. But yeah, has anyone got any other questions? No? Okay, but thank you so much. I think that's been so helpful. And yeah, really appreciate it.